I'm going to start.
On that note.
All right. Well, thank you everyone that's come today. I'm going to be talking about severe mental illness in the CKD patient population. General outline for the presentation will define mental illness in general, discuss its prevalence in the general patient population, and the mortality gap of patients with severe mental illness. Then we'll be establishing the relationship between severe mental illness and the development or progression of CKD. And then lastly, we'll identify, review, define a couple of the most common severe mental illness conditions in patients with CKD and their respective pharmacologic treatments. I have no official disclosures, but I am married to a psychiatrist. Okay, so mental illness, defined as a mental, behavioral, or emotional disorder. The big differentiator between someone with mental illness and severe or serious mental illness is the degree of impairment. So if someone has a very serious mental illness, that means a very serious functional impairment that's affecting them on a day-to-day basis with just daily functional activities. So most common mental illnesses, you have mood disorders, that includes MDD and bipolar disorder. We have anxiety disorders such as panic disorders, GAD and PTSD, eating disorders, impulse control disorders, ADHD, autism, and schizophrenia. So today we'll be later on talking about mood disorders and schizophrenia. Now, mental illness prevalence. Just real quick. So this is from SAMHSA from a couple of years ago, and the general adult population of the United States. Overall, 25% or 23% of the population had any degree of mental illness. This is self-reported from the patient. 26% female, while 19% men. Generally speaking, it skews towards the younger age groups. And then what I thought was interesting is for differentiation between race and ethnicity, is that you can see that patients that have a very diverse background, much more likely, or it's more prevalent for them to have any degree of mental illness.
Do you want questions in the end?
You can interject.
I was just wondering if some people feel more comfortable reporting this data than others.
Exactly.
Like in one hand, stigma.
Yeah.
Could be, if you can have mental illness, you cannot have a weakness. Right?
No, I completely agree. I think that's why you see the, 7% difference between at least men and women at the very least. But yeah, I agree. And then for severe mental illness, it's the general same trend of between men and women, between the age groups, and between race and ethnicity. That's it for prevalence. Now we'll talk about the mortality gap in patients with mental illness. So what is mortality gap? I think it's a phrase that most of us are familiar with because there is a mortality gap with patients with CKD or ESRD compared to the general patient population. But it's used to differentiate life expectancy in patients with, in this case, severe mental illness compared to the general patient population. And then we're going to be going over the evidence that SMI is associated with premature death. So this is a study, I believe this is a Danish study from a couple of years ago, where their goal was to evaluate mortality rate ratios and years life lost between patients with severe mental illness, or mental illness rather, and 11 groupings for all-cause death. So for your disorders, you have organic disorders that includes dementia and Alzheimer's disease, then substance abuse, which will be the highest, but then schizophrenia, mood disorders that combines MDD, and that includes bipolar disorder, neurotic disorders, eating, personality, intellectual disability, developmental disorders, and behavioral disorders. And then for the categories of death, it's, respiratory, digestive, cardiovascular, developmental. I wanted to just show this real quick. We're not going to go into it in a lot of detail, but want to just point out that the mortality rate ratios among all groups that have any degree of mental illness, there was an increased mortality rate compared to the general patient population. That's the main thing I wanted to point out on this slide. And these are all review. Yeah.
I don't see depression in there. I don't see depression.
It's combined mood disorders. Depression is under that umbrella.
Okay, and this is self-reported, or this is
ICD-9? This is based on the ICD codes.
Okay, so this is very different. We're not talking about somebody with mild depression that they never told the doctor about.
Correct.
Or moderate depression that their primary care doctor gave them, and that's something that but never coded for.
Correct. This is someone that has been diagnosed with either for mood disorder specifically, major depressive disorder, or bipolar disorder.
Major depressive disorder. That's
Yes.
very different. Okay,
Yeah.
so I'm.
I should have specified it. Thank you. Okay, and then for the mortality rates, I just wanted to emphasize schizophrenia because I feel like that's not something that we talk about very frequently, but just wanted to point out that the mortality rate ratio for both schizophrenia and mood disorders, generally speaking, is higher than the general patient population. And then additionally, that the life expectancy between men and women is shorter. Specifically, I want to point out that men it's about 10 years, and then for women it's about 7 years or so than the general patient population. Next, I have an article or population-based cohort study that was in the World Psychiatry Journal, and it's more or less kind of examining the same things. We have mortality rate ratios, but in this time they're also looking at patients with overlapping diagnoses based on ICD codes and the reduction in life expectancy for each mental disorder. This is a very busy slide. I mostly just wanted to point out just two things. One, the general patient population here, I think this was either a Danish or Swedish study, but their general patient pool for this was about 5 million people. When I pointed out 89% had no diagnosis of any mental illness. And then you can see 1, 2 in the overlaps. And then I wanted to, again, point out that the spread between ages, it's similar to what the prevalence was in the United States. So this is how they decided to display the overlaps between the different disorders. So one dot, for example, up here, we have neurotic disorders. So that's like GAD, that's like PTSD and panic disorder. And then if you come down here, you can see that this is a combination of neurotic disorder and mood disorder. So that's a patient that has both diagnoses, that have been diagnosed with both of them. So it is a very interesting way to display the data. But I think overall, you can see that there is a higher mortality rate ratio for anyone with mental disorders, but then the reduction in life expectancy is also pretty significant. You can see, I think the highest one is organic disorders and mood disorders combined, and is about, in this patient population, was about 14 years or so. I want to just point out again, schizophrenia specifically, the same general trend of higher mortality rates compared to the general patient population, and then years lost. So now we'll be going over the relationship of mental illness with chronic kidney disease. So this was from C. Jason in 2022. This was more so just trying to come up with a game plan or identify where, so some patients might be more prone to developing CKD, and what are areas that we could address as a group. So they focused on severe mental illness, specifically schizophrenia, bipolar disorder, and schizoaffective disorder. Patients that have severe mental illness, they typically are just, I guess this is a generalization, but it has been proven. I don't have the data for this, but they have smoking, they are generally more likely to smoke, don't have restricted diets whatsoever, less likely to exercise, and they are frequently seen to have substance abuse problems, disorder. And we'll be going for the treatment of SMI, we'll be going over antipsychotics and mood stabilizers. But generally speaking, antipsychotics, the side effects of some of the medications make them more prone to developing chronic kidney disease. And mood stabilizers, for example, lithium, which we'll be talking about later, has been shown. There is some papers or data supporting that lithium can cause chronic kidney disease or chronic interstitial disease, tubular interstitial disease. So then combined, you have a patient that might develop CKD. Patients with CKD and severe mental illness, high morbidity, there is a mortality gap that we discussed for both severe mental illness, but also patients with CKD. And then access to care in general, patients that carry the diagnosis of severe mental illness, I think it can overshadow the general diagnosis for a patient. It is a barrier to transplant, and then it's been shown that these patients generally are less likely to seek specialist care. So that's what I wanted to focus on for this study specifically. Next, I have a population-based study from Israel that really just, I wanted to touch on it, which looked at schizophrenia. Is it associated with CKD? And then does it affect accessibility to dialysis and kidney transplantation? The answer for both is yes. is a higher risk, the patients with schizophrenia are higher risk of developing CKD. And then they're less likely to receive treatment for CKD and also kidney transplantation. I wanted to show this graph from that paper just to demonstrate the likelihood of that patient population with schizophrenia to be smoking, to have obesity, to have diabetes, and hyperlipidemia. And then briefly want to talk about NDD and CKD. I didn't find any papers that demonstrated that a patient with NDD specifically was a higher had a higher chance of developing CKD, but we do all know the relationship of patients that have CKD or ESRD that are likely to develop depression in some. Okay, and then that brings us to this paper, which I think this article comes out today. So this is from, the article was from Sweden. It's about prevalence of severe mental illness in association with CKD. So they ended up ultimately doing a cross-sectional design and a cohort design. So they had about 53,000 people registered in their renal registry over a 12-year period. They excluded anyone under the age of 18, anyone that didn't have a GFR, or they actually excluded patients that were CKD stage 3 or better. So this is pretty much anyone that's CKD stage 3B, 4, and 5. Then they, yes, so now looking at the cross-sectional design, we have patients with incident CKD. What they mean by that is this patient population that developed CKD during that 12-year period. And then they looked at the prevalence of severe mental illness compared to the general patient population. And then about 30,000 patients with incident non-KRT CKD. They looked at the association between severe mental illness and general health outcomes. So again, another very busy slide. Just wanted to focus on a couple things here. One, this is just the general patient population overall and severe mental illness. But I wanted to, so 70 years is the average age, but I wanted to just look at the age of schizophrenia is typically about 9 years younger or so. Two, I wanted to focus on just the spread between patients with CKD stage 3B, 4, and 5. Generally speaking, across the study, the highest grouping is in stage 4. And then the causes of kidney disease in this patient population. So generally speaking, obviously high blood pressure and diabetes. I couldn't find rather, what they included in other specific causes of chronic kidney disease. But what I did want to point out here is when we look at bipolar disorder and we see the lithium nephropathy of 52%, that is just, it's just based on what the patient was diagnosed with. There was no biopsy that proved that the patient had any findings consistent with it. It was just based on the fact that the patient had bipolar disorder, was on lithium, and they attributed their CKD to lithium nephropathy. Okay. So this is the incident of developing CKD with any severe mental illness, schizophrenia, bipolar disorder, and major depressive disorder. Overall, across the board, just like the other studies that we've kind of looked at, higher prevalent rate of a patient with those conditions to develop CKD. I think what I wanted to point out is on the next slide. Okay, so this is just comparing this. On the left was the incident CKD, so patients that developed CKD during the trial, but on the right, it's also including patients that had CKD kind of going into the trial. Okay, but generally the trend is the same across both groups. Okay, now we look at the patients with schizophrenia, 30% decline in eGFR, renal replacement therapy, all-cause mortality for schizophrenia, bipolar disorder, and NDD. The biggest takeaways that I noticed when they adjusted for different variables, and forgive me, I can't remember what specific variables they adjusted for, but it is listed in the paper. All-cause mortality in schizophrenia was higher compared to the general patient population. Bipolar disorder, I guess, yes, technically. And then also borderline for all-cause mortality in NDD. Do you have a question?
Are they comparing to the general population, or are they comparing to patients with that mental illness who do not have CKD? I
I thought it was for patients. I thought it was against the patients with.
CKD.
It's patients with CKD.
On the topic,
Yeah.
non-care,
Yeah.
CKD, with mental illness, without mental illness.
Well, it doesn't say that who the comparison group is, it says the association between their outcomes. And so is CKD worsening their outcome?
Well, they all have CKD, right? Because the whole cohort is incident CKD. If you go back to the flow diagram. So everybody has CKD, right? And then there's some people that go to table 1. And so you have the no severe mental illness and any severe mental illness, and then there's like
Okay.
any severe.
But they include in patients with no severe mental illness.
That's the reference group. That's the reference group. Right? That's the group.
But shouldn't the reference group be, if you look, so I guess if the question is there an interaction of CKD and mental illness? In the reference group,
They can't answer that question, right? Because everything is CKD. Let's go. Right? They didn't have a group without CKD. And without.
right, so my question though is CKD worsening their outcome?
Doesn't sound like this study is designed to my question.
Yeah, to me, that's the impression. That would be that's my question.
This is a good question that we don't have an answer to. And then they look at the patient's association with patients with severe mental illness and the likelihood of them being started on dialysis or kidney transplantation. And the trend is generally the same in the sense that they had lower access or less likely to start on dialysis or receive kidney transplantation. So generally speaking, their conclusions for patients that had schizophrenia, compared to patients with bipolar disorder and major depressive disorder, there was a stronger association with all-cause mortality. Higher percent of patients with CKD stage 5 in the stage group with schizophrenia. Patients, and we'll touch on this when we talk about the medications and such, but patients with schizophrenia are at a higher risk of developing cardiometabolic conditions, including hypertension, diabetes, metabolic syndrome. And then that's directly related to that, in part directly related to the antipsychotic use in those patients. For bipolar disorder, the conclusions from the paper, from the study or review, bipolar disorder is 3 times more prevalent in patients with CKD than the general patient population. And it's due to a couple of different factors. They said lithium could be an important contributor to CKD because there hasn't been something proven. Everything that I saw was still theoretical at this point. There was a faster decline in EGFR, and that patients that with bipolar disorder were a risk factor for declining in kidney function independent of lithium exposure. And then their conclusion for major depressive disorder is that it increases all-cause mortality. Oh, so if anyone missed the code.
This is like some 6th class wired now.
Great.
This is just a visual abstract of the paper. All right. So most common mental illness conditions in CKD and ESRD. You have the mood disorders, that includes MDD and bipolar disorder, anxiety disorders, neurocognitive disorders, substance abuse, and schizophrenia. We'll be talking about the mood disorders and we'll be talking about schizophrenia specifically. All right, welcome to Psych 101. Here we go. So this is the picture that I think of when I think of schizophrenia. So we'll define schizophrenia, comorbidities, treatment options, and then the relationship with CKD. So the average age of onset of schizophrenia is typically your late teens up to your early 30s. It happens, onset is typically earlier in men than in women. The average estimated years lost for patients with schizophrenia is roughly 28 to 29 years or so. Co-occurring medical conditions of patients with schizophrenia include heart disease, liver disease, and diabetes. And then the question of nature versus nurture. So I think they did a study between twins. If one twin had schizophrenia, I think there was a 40 to 50% chance that their other twin would then go on to develop schizophrenia. And honestly, I'm not sure how they discovered this, but they said that if a mother had high IgG antibodies to toxoplasma, that also increases the chances of the fetus eventually developing schizophrenia. Other things includes smoking and marijuana use, in addition to the mother themselves having schizophrenia. So I wanted to just quickly include these, mostly to focus on the fact that schizophrenia patients or patients with schizophrenia are at increased risk of developing type 2 diabetes. The longer you have schizophrenia, the higher chance of you developing diabetes, and that patients with schizophrenia that are on a second generation antipsychotic have a higher risk of developing metabolic disorders than those on the first generation antipsychotics. So this is also a very busy slide. This is directly from the DSM-5, which I do have at home. So I wanted to focus on just a couple of things. One is mostly just discussing the definition of the first criterion, because you need to have at least one of the patient has delusions, patient has hallucinations, or disorganized speech. One of the three. In addition, they should have grossly disordered, be generally disorganized, or have catatonic behavior and have negative symptoms. Additionally, we were talking about impairment before. To have schizophrenia, you need to have a significant impairment, whether it is an interpersonal impairment, whether it's academic or professional, but their disorder causes such a disturbance that they're not able to perform appropriately. So your treatment options, you have your first generation antipsychotics and your second generation antipsychotics. Now that there have been numerous second generation antipsychotics, they have become much more prevalent as opposed to the first generation antipsychotics, purely due to side effect profile. Talking to Nisha, when prescribing medications, they are primarily looking at the side effect profile and then the patient individually, as opposed to just always going with one specific medication or going always first generation or second generation. They're very much looking at just the side effect profile and the patient's ability to adhere, whether the patient has if adherence will be a problem or not, because some of the second generation antipsychotics have it's an injectable or there's a depot, something like that, so that way they can make sure they're still getting the treatments. I'm mostly going to put this slide up. This is directly from the American Psychiatry Association guidelines on schizophrenia. I mostly just wanted to look at the dose adjustments needed for renal impairment. So most patients aren't on first generation antipsychotics, but I do know occasionally some patients in the hospital will get either Thorazine or Haldol. For Haldol, there's no dose adjustment that's needed, but anyone that gets Thorazine, it's not dialysable, so just be very cautious with using it. Continue first generation. Your second generation antipsychotics, Abilify is very common, frequently used. No dose adjustment is needed for Abilify. Rexulti, I'm sure people have seen the commercials for Rexulti, but for patients with some degree of reduced renal function, you do need to reduce the maximum dosage that these patients receive when they do have CKD. We have clozapine, which is less used now than it used to be, but which we'll talk about in a second. But there is a dose reduction might be necessary for patients that are on clozapine. We have Latuda and Zyprexa. Zyprexa is not dialysable, and Latuda, they recommend just reducing the dose overall. Seroquel, no dose adjustment is needed. And then Risperdal, you do need to reduce the dosage if you have worsening CKD. And that's GM. Okay, so this is just very quickly wanted to point out the receptors that these antipsychotics are antagonizing. So the first generation are primarily anti-dopaminergic, and your second generations, generally speaking, are more anti-serotonergic. Some of the second generation antipsychotics do have some dopamine agonism, but for the most part, the first generation will be anti-dopaminergic and second generation anti-serotonergic. When patients are started on antipsychotics, they get baseline for both obviously family history, weight, blood pressure, checking for metabolic syndrome. After 4 weeks, they'll check the lipid panel again occasionally. And then every 12 weeks out, they kind of reset, make sure the patient's doing okay. 12 weeks is generally the guideline when it comes to medications to see if the patients are tolerating them well. And then whether it's quarterly or annually, they're always checking if the patient is developing any side effects from the medications. So this is going to be your side effect profile for your antipsychotic, specifically second generation here. Did I put the arrows on this slide? No. Okay, so clozapine has a lot of side effects, even though it is a very effective medication. It's not frequently prescribed because significant weight gain, glucose abnormalities, patients with a little hyperlipidemia, and that's not even talking about like the agranulocytosis that the medication causes. Olanzapine, also a very effective medication and frequently used. Patients generally tolerate it well and it's effective. However, same problem with the medication, and it causes weight gain, it causes glucose intolerance and hyperlipidemia. Some of the second generation antipsychotics here, like quetiapine and geodon, are much more associated with QTc prolongation as well. This is the adverse effects or side effect profile of your first generation antipsychotics. Mostly just wanted to point out that we have the class. You have akathisia, Parkinson's dystonia, tardive dyskinesia, elevation in prolactin, and they can be fairly sedative, as well as anticholinergic activities. So that is why, generally speaking, these classes of medications have kind of fallen out of favor. Okay, so this paper, I believe, was, 2020, second generation antipsychotic use with the risk of developing CKD. Generally speaking, there's just an association that patients that were on all second generation antipsychotics, except for Abilify, had an increased incidence or increased risk of developing CKD. This is from the paper. This is the only thing I wanted to show, but it's more or less saying the same thing. But I wanted to show that Abilify decreased odds of developing or incident CKD as opposed to the other antipsychotics. But again, clozapine, I know that the spread is fair, or the confidence interval is fairly wide, but that one of the reasons the medication is falling out of favor. So now we're going to talk about major depressive disorder fairly briefly. Depressive disorders as a whole, that includes MDD, dysthymia, disruptive mood disorder, disruptive mood dysregulation disorder, premenstrual dysphoria, substance or medication-induced depressive disorder, and then depressive disorder from another medical condition. We're just going to briefly talk about major depressive disorder. So just the prevalence of depression in the general patient in the United States. Again, this is self-reported as opposed to ICD codes here, but it's the same general, I guess you could say, trend as the graphs or incidence graphs that we looked at. So the DSM-5 criteria, the patients need to either have definitively either a depressed mood or anhedonia, and then a combination of your other symptoms for a total of 5 symptoms. So one of them has to be depressed disorder, depressed mood, and anhedonia, and then a combination for the other 4 of unintentional appetite or weight change in their weight, insomnia, agitation, fatigue, worthlessness, suicide behavior, or decreased ability to focus. This is an example of a depression screening that is used for patients to see if the patients, have depression. It's just self-reported. So antidepressants as a whole, we have SSRIs, we have SNRIs, we have trazodone, bupropion, and TCAs. So SSRIs are used for MDD, general anxiety disorder, OCD, PTSD. Again, serotonin selective reuptake inhibitors are increasing the serotonin and the synaptic cleft. The Medications include citalopram, escitalopram, fluoxetine, fluvoxamine, paroxetine, and sertraline. The side effect profiles we are familiar with, so citalopram and escitalopram, you have QTC prolongation. The class effects, generally speaking, you have hyponatremia. I could not find a specific mechanism as to how it causes SIADH, but it's believed that it can increase the release of ADH at the hypothalamus.
This is a hypothesis, right?
Hypothesis.
Like even the cause, it's associated.
Yes.
No one has put what is the cause,
Yeah.
nobody has stopped it and shown the reversal.
A lot of the medications are theorized about how they work or how the side effects occur.
Associations, I think everything with association. That's like,
And then obviously serotonin syndrome is also associated.
I wanted to point out, it's different.
The causing versus an association.
Yes, the hyponatremia and serotonin syndrome, here we put in the hyponatremia as if it's causing like mechanism of action.
Yeah.
But all the data is from retrospective study about patient having hyponatremia and having as a saliva vote. Compared to serotonin syndrome is a mechanism of action.
Yeah.
Where you should look out for it. Of course, you should look for hyponatremia, but my point is,
Mhm.
it's very different.
Thank you. Yeah, okay. Next up, we have SNRIs, that includes duloxetine and venlafaxine, MDD, GAD. You can see all the different uses. For duloxetine, they recommend not using it for patients with CKD4, and they recommend not using it if the patient is on dialysis. For venlafaxine, they actually recommend just reducing the overall dosage. If you're going to start at half the normal dose, and if the maximum dose is also higher. The safety data is from an article back in 2012, so that's where the information for is it safe to use in CKD, is it safe to use in ESRD, that's where this comes from. A lot of the studies also, when they say it's safe or not, comes from a patient pool of like 3 to 4 patients. It's very small, and they just kind of see the levels or how the patient responded. So it's not the most strong, it's not the strongest data. Trazodone specifically, it's a serotonergic receptor antagonist. And then bupropion is that mechanism of action is also theorized. It's not confirmed, but they suspect that is a norepinephrine and dopamine reuptake inhibitor. The medications are non-dialytic. That's what I think. Okay, and TCAs, they're very much falling out of favor in for treatment for major depressive disorder, but I included it because we still will sometimes see it for patients with neuropathy. Has a very broad mechanism of action, and then the side effects are very profound, especially the cardiovascular effects. And then I just included this again just for comprehension's sake forward, just to show that dose adjustments are needed the more extensive the patient's CKD is. All right, so now we go to bipolar disorder. We'll talk about the definition, the treatment, and then lithium in general. So bipolar disorder, that's what people are familiar with, the manic depressive. Oh, I'm doing great on time. Okay. Sorry. Manic depressive disorder. You have significant changes in mood, energy, activity levels on a day-to-day basis. The average age of patients with bipolar disorder for 1 is 18, for type 2 is 20. The difference between type 1 and type 1, you have patients that have mania. And obviously depression. Type 2, the patients can be hypomanic, which is grossly speaking, a toned down version of mania. And they can have major depressive, but you will never see a patient with type 2 that is manic. If the patient has mania, if they are manic, that makes them a type 1 bipolar. They have type 1 bipolar disorder. So what does manic mean? So you have at least 3 from this category, but generally speaking, the patients need to have an elevated, expansive, irritable mood. They need to have a very high self-esteem, very much reduced sleep, less than 3 hours or less. They're very talkative, more than usual, and pressure to keep talking, like how I feel right now. You have a flight of ideas for these patients. They're easily distracted. And then I don't really know how to properly phrase this, but the examples for doing things that may not be in the best sequence with painful outcomes, such as investing in a business that is not a good idea. So those would be the type of symptoms that you would see for a patient that is manic. The treatment for mania. So it's either lithium or valproic acid. plus either a first generation antipsychotic or second generation antipsychotic. So for lithium, it's the preferred agent. However, if a patient has CKD when they're manic for the first time of receiving treatment, they try to avoid it. If a patient has a history of liver disease, or if it's a young female, they try to avoid valproic acid. If responsive to treatment, that typically depends if they're inpatient or at a crisis center. They typically try to wait at least 1 to 5 days. If someone is still incredibly uncontrolled, they'll just do it after a day, but they try to wait the 5 days to see if they respond. If they don't respond, then they'll switch the lithium to valproic acid or vice versa. Then they try to wait again another 1 to 5 days. Unresponsive, they change the antipsychotic specifically. And then worst case scenario, they either continue to switch antipsychotics or they do electroconvulsive therapy. This was from a review paper back in 2014 about the discontinuation or the efficacy of these antipsychotics. So on the left, you have, this is all, I believe, from the psychiatrists themselves, if the patient did respond well to treatment. So on the towards the right here, that means that they responded very well to treatment. So risperidone, Haldol, olanzapine, for example. And then on the right here, on the right over here, that means that the patients were likely to discontinue the medication. So if you see, for example, olanzapine and risperidone, quetiapine, the patients were more likely to continue the medications, not just abruptly stop it. So you'll see risperidone and olanzapine specifically, very high in both the curbing the mania as well as low discontinuation rates. But I want to just point out here, though, that again, those two medications give significant side effect profile. Very important for patients with CKD, that weight gain, glucose intolerance, hyperlipidemia. So treatment for hypomania and depression without active mania, you can do. They use quetiapine and Latuda, second generation or second line. If that doesn't work, you can use valproic acid or do a combination of an antipsychotic and an SSRI. Okay, now that takes us to lithium, the last topic of the day. Used in bipolar disorder and then major depressive disorder. So for acute mania, they recommend starting at 600 to 900 milligrams a day and ultimately increasing it to a total daily dose of 900 to 1.8 grams per day. Generally, the goal is not to titrate the medication to make sure the patient is therapeutic. The goal of therapeutic according to a goal level of 0.5 to 1.2 milliequivalents per liter. The goal is to curb the patient's side effects. You could theoretically improve the patient's symptoms by being subtherapeutic, but you will never need to go, the patient, if you have a drug level greater than 1.2, the patient should definitely not still continue to have side effects, if that makes sense. So it's possible to control their symptoms with a lower than expected goal, but you're never going to have uncontrolled symptoms if you're above the goal. MDD, they recommend starting at a lower dose, and generally speaking, it's about 2/3 of the typical doses as you would for acute mania. So side effects of lithium toxicity: for low-grade toxicity, you'll see more nausea, more diarrhea, ataxia and tinnitus. When it's more severe, you're seeing more significant neurological symptoms like slurred speech, confusion, seizures, and even coma. So chronic toxicity, so mild toxicity, you typically see when the trough levels are 1.5 to 2.5. And you'll see more tremors, slurring speech, and general lethargy or mild lethargy. If you see mild to severe toxicity, you would expect to see worsening lethargy, coarse tremors, and you'll see spontaneous clonus. You can see that anywhere from 2.5 to 3.5. If a patient has severe toxicity, you expect to see that after 3.5. And again, the serum lithium concentrations don't actually often correlate to the clinical signs of acute toxicity because the medication is very slow to disperse to the rest of the body. So in other words, while medication is dialyzable, it's still, for it to be removed from the CNS and vice versa, it takes a significant period of time. So while the trough might say the patient's level is like 1.8, they might have still some significant signs and symptoms that would be concerning, and you might need to ultimately dialyze the patient. And you need to be careful about rebound effect if you do dialyze the patient. So lithium's mechanism of action, they don't technically know, it's all kind of theorized. This is a Jackson Pollock. But with that being said, back last year, what their most current thinking is for the mechanisms of action, you have inhibition of glycogen synthase kinase 3, as well as the other protein kinases, but I wanted to focus more so on glycogen synthase kinase 3, and I'll talk about why in a second. But it's supposed to theoretically ultimately reduce mania, depression, suicidality. It's one of the most effective medications for bipolar disorder. That's why it's still there, even though it is associated with causing CKD. And then it decreases apoptosis, oxidative stress on ER, and the endoplasmic reticulum stress. So this is a super busy slide. This is the whole caption for it, but more so, I wanted to focus on the GSK3, the glycogen synthase kinase 3, and lithium's relationship with it. So it will shut down GSK3, and it will also phosphorylate GSK3. Subsequently, you'll have reduction in oxidative stress. You'll have increased transcription of VEGF, IGF, and several other. And I think that's mostly the things I wanted to focus on. You'll have inactivation of the inflammasome. And one of the associations with shutting down GSK3 specifically is that you'll have increased COX-2 and subsequently increased prostaglandin E, which we'll talk about in 1 second. Here, I want to talk about ABP in general, which is obviously why, but ABP, you'll have increased, when it binds to the receptor, you'll have increase in adenosine cyclase, increase in CAMP, increase in pKa, and subsequently you'll have increased exocytosis of aquaporin channels, decreased endocytosis of aquaporin channels, and then increased gene transcription of these channels. Bringing that up because, again, lithium will go through the ENEC channel and the principal cell in the collecting tubule. The channel has, I think, a 1.5 to 2% or 1.5 to 2 times higher affinity for lithium. So when it goes into the cell and it shuts down GSK3 and subsequently also increased COX-2 production, you have increased prostaglandin E production. The combination also subsequently leads to increased endocytosis of the aquaporin channels. You have decreased exocytosis of the aquaporin channels. Subsequently, you can't, absorb as much water. And while you have lithium coming into the cell, it can't actually leave via this NAK2 ATPase channel. So you have lithium end up staying in the principal cell, and it's been theorized that it promotes apoptosis and ultimately leads to chronic interstitial lung disease. So the treatments for lithium-associated ADP resistance, amiloride is theorized as one of the treatment options and inhibits the ENEC channel. The studies that I saw had, I think, less than 10 people in it, but they said that there was an improvement or reduction in the urine output. But between amiloride and between hydrochlorothiazide, you be very careful about the patient's volume status. If you end up volume depleting the patient, you're going to increase the levels of lithium, and then you're in an endless cycle. Indomethacin, prostaglandin E inhibitor. The problem with that, though, is it's been reported that by doing that, you actually end up causing increased absorption of lithium in the ascending limb. So the people also do not use indomethacin. So I put slippery slope because why even try it? There is an association between lithium and hypoparathyroidism as well. It's one of the mechanisms is you have increased calcium sensing receptor threshold at the parathyroid gland. So subsequently, you have continued PTH secretion despite a patient being hypercalcemic. We talked about the GSK3B. So that in itself, it has been associated with increasing PTH overproduction. And subsequently, it's been shown that 33% of patients with lithium that have lithium-induced hyperparathyroidism develop parathyroid fibrillation. So should you use lithium in patients with CKD or ESRD? It's a risk versus benefits thing in the sense of if the patient's mania is well controlled, this might be something that you ultimately decide it's better for the patient to continue their well-controlled treatment option versus the risks of continuing it. And we talked about the rebound effect. So, okay, summary. So patients with severe mental illness have increased mortality gap compared to the general patient population, similar to like those with CKD. There is a relationship between patients with severe mental illness and the development or progression of CKD. SSRIs have significant side effects, but also associations that can be, and they can be used in CKD. Antipsychotics predispose patients to conditions that increase their chances of developing CKD, and then lithium is also mysterious. And that's it.
I mean, this is wonderful, and I think that we should do from time to time nephrological discussions, so it's great. I was, and this is a most peripheral question, but I see that you're showing the depression in general population around 10 to 12, 14% in the early age group, and then it almost halves or becomes 1/3. Are these transient depression? What type of depressions are these which are going away? Because most of the major depressive disorders, my understanding is, and you can please feel free to correct me, are pretty steady, lifelong chronic condition rather than transient manifestations. Why do you think that almost 2 or 3 times higher incidence of prevalence in the early age group? There it is.
That's the self-report, right?
Yeah.
Yeah, so I understand, but people are not dying that much. Like 18 versus 4 or 5%.
There is more awareness, younger people are more aware of mental disorders, so they like to report more than other. I would guess, that's my guess, that's what I.
And
So
social media.
this is the new epidemic of depression. I thought it was an old one. Like 80s people knew that they are depressed, right? Or is it new?
I would think it's probably just related to awareness of the fact that that condition is there and that people have it. So I think people are getting evaluated earlier on. Or again, it's self-reported. So
And it depends on where they did the survey, right? I mean, you can do US for survey, of course, it's gonna be.
And what year? This is 1 year.
2021. I mean,
What year?
I would suggest this.
yeah, the tail end.
Young people are depressed more with COVID. This looks up.
As you are an expert in the mental disorders, latest hype, I would say, because we don't have data for it, is hallucinogen. Do you have any knowledge about hallucinogen?
I have no knowledge. You want me to find out? I can find out.
I thought you would have.
No.
If I'm writing Rara, I'll be lost in this reading about hallucinogen. And they suggest that there is a role of treatment with hallucinogen, right? That's the latest. Yeah.
Yeah.
LSD, yeah.
I mean, I just had forget that question. People will ask us, can I take this mushroom supplement?
Random mushroom.
I think I
Came out and then an outpatient goes to build the kidney stone, the shit was related to the mushroom. I don't think that's the case. I think it's more being evaluated and imaged. But yeah, for him it didn't end so well. I mean, he's alive, but ICU stay was notable. You don't try random mushrooms. And buy them from the grocery store.
Sinha has a big poster now, on the different kind of mushrooms and the toxicity.
I saw that.
Yeah.
I saw it, yeah.
He was looking for that hallucinogen.
This is great. Can we come to you whenever we have?
You should come to my way.
You are, no, because I think what you're highlighting is that, I think this is, if I can tell you for myself, I don't know whether the rest of the people feel that. But a part of this is because, I don't know, you're unique. My wife is a neurologist and I stay as far away from the topic as possible. So, but I think a part of this is that most of us shirk away from the mental illness diagnosis / treatment, and we usually hand it off. And so I think, especially for subspecialty people, and nephrology is uniquely primary care oriented subspecialty, that I think for CKD patient, there may be one, whether there is increased prevalence or not, I don't know that part. But I think there may be increased chance of mismanagement of these disorders because these people rely on us for primary care, which we actually don't provide in psychiatric clinics.
I have a question.
Sure.
I don't know if maybe this was in the data that you presented and I didn't, but you're understanding well, but was there any evidence that patients who were better controlled from their mental illness had like less probability of developing CKD in the future?
They didn't go that far into it.
Okay.
They just found associations if the patient had the diagnosis or if they were on the medications that would treat their conditions and then the development of CKD.
Okay. That would be
There's so much
interesting.
more to it too. It's not just medications. I mean, we see all the time, you know, patients with mental illness on dialysis, they have no social support.
Mhm.
It's over. You know, you can do all you want, prescribe all the Sensipar binders and all that you want and set them up for appointments and they're just not gonna make it, you know? So it's a complex population.
I think they should expand the diagnosis of schizophrenia from 2 to 1. Half the population will be on that.
Wrong business investment.
Yes, yeah,